This video describes the second, third, and the fourth step of the PREM process. What is done immediately after performing the modified rapid cardiopulmonary cerebral assessment. How to document in the PREM case record. How to interpret the vital signs. And lastly, how to derive the physiological status using the PREM triangle. On the 12th of May 2025 at 10:30 am, a 5-month boy is brought to the emergency OPD with a history of fever for 2 days, incessant cry since morning. He has no other complaints. He is developmentally normal. He has no comorbid conditions. Has not received any pre-hospital care. Airway stable. Breathing. Respiratory rate 60 per minute. No grunt, no stridor, retractions plus, abdominal respirations, bilateral pulses are 3 plus 2 plus, color flushed, abnormal. He's warm throughout, heart rate 180 per minute, CRT less than 2 seconds, no gallop. Liver span 6 centimeters normal. He's responsive to voice, eyes mid position. Extraocular movements normal, tone and posture normal, pupils equal, reacting to light. Blood pressure 80/0. Since mum reports incessant cry, disability is interpreted as altered level of consciousness. This 5-month infant had a respiratory rate of 60 per minute, which exceeds a normal range of 40 per minute for that age. Increased respiratory rate plus retractions equals to respiratory distress. The infant's heart rate is 180 per minute, which exceeds the upper limit of 170 beats per minute for that age. So the infant has tachycardia. The liver span is 6 centimeters, which is normal for the age. Systolic blood pressure is 80 millimeters of mercury, which is within the normal range of 65 to 106 millimeters of mercury. It is expected that systolic blood pressure should be much higher since mom has reported incessant cry, a sign of hypoxia or shock. Hence, systolic blood pressure indicates, that is, the 80 millimeters mercury indicates relative hypotension. The diastolic blood pressure is low at 0. Hence, pulse pressure is calculated as wide and MAP is 26 millimeters mercury, which is low for age. Since the infant shows signs of respiratory distress with no apparent lung focus such as cough and cold, it can be hypothesized that the respiratory distress is due to acute lung injury or pulmonary edema. With low MAP vasodilatory shock, the physiological status may be interpreted as vasodilatory cardiogenic shock with low MAP.